Remember, there are maximum number of forces which are acting in the subtrochanteric region. We all know what are the things that which are all the muscles that are acting on the proximal femur, thereby leading on to the typical deformity. The typical deformity is that the proximal fragment goes into abduction, external rotation, and flexion. Okay. So out of which abduction and external rotation we can make out in an AP view, and flexion will be able to make out in lateral. Now this is the lateral view. It is flexed. In AP view, it is abducted. Things are going into varus and externally rotated. Okay, so that's the common deformity and the deforming forces that we need to overcome when we reduce a acute subtrochanteric fracture whenever we are treating. Now, this was way back in 1907. This is from Koch's textbook, where yeah, he had clearly mentioned that if you could see the entire femur and we could see the forces acting at different regions of the femur, the maximum force is acting in the subtrochanteric region. Okay, that's nearly about 6 times the body weight. So that much amount of forces are acting on the subtrochanteric region. So this is one region in the body where a lot of mechanical stresses occur and a lot of deforming forces occur. Now, all these leads to a very common problem that we all face, which is usually non-union, but sometimes it may even end up in malunion. Okay. So, and we also know from a biomechanical standpoint that whenever there are significant bending loads, then the failures of implants are higher. Now, this bending loads failures per se, we all know that angular forces are not greatly tolerated by a nail. They are okay tolerated by a plate. Okay, not that both are great, but amongst nail versus a plate, a nail is slightly poorer compared to a plate. So chances of a nail failure is much more higher, and hence that doesn't mean that the next time you encounter a subtrochanteric fracture, go and plate this. Okay, it just means that nailing still gives great results because of all the advantages biological that we have. But as a surgeon, it becomes much more important to look into a appropriate reduction and providing appropriate stability when you are treating this with the nail. Okay, so the compressile and tensile forces, we are all aware of that. The medial side is compressile and the lateral side is tensile force for the subtrochanteric region of the femur. Okay, so when you deal with the acute fracture, the key step is the reduction. If there is one thing that will happen if you do not reduce, it is definite non-union. Okay, so it's very, very rare that a mal-reduced subtrochanteric fracture will go on to unite, because like I told, because of the forces acting so much that there will be instability and there will be a definite non-union. That's a very common thing that we see, right? They're highly prone for mal/non-union, not because of the fact that they're in subtrochanteric region, but because of the fact that our reduction, final outcome of a reduction may not be great. Okay, the issue as found in literature is that almost 1 in 5 cases, 20% of subtrochanteric fractures are mal-rotated. Now, this is especially more worrisome whenever we have a subtrochanteric comminuted fracture. Okay, if we do not have a comminuted fracture, we have a simple fracture pattern. It is much easier for us to correlate our rotational malalignment, because we'll be able to see a clear mismatch between the cortical thickness in the proximal as compared to the distal. But when we have a comminuted segment, then this particular entity we will not be able to really understand, and chances of malrotations are very high, 20%. 40% in malangulations. Now, rotations at least may be difficult as a surgeon for us to recognize, but malangulation is actually very, very easily recognizable. And even then, 40% of our cases are ending up in malangulation. Now, that's worrisome, because what meets the eye, if you are not able to correct that and if you're not able to take care of that, even though we know that that is bad, even though we know that that is a high potential for non-union, then definitely we really need to take significant measures to be able to correct. So 40% is an unacceptable percentage, and 50% in shortening. Now, again, this is mostly with respect to comminuted fracture, but having said that, even in simple fracture patterns, especially the spiral fractures or oblique fractures, there may be some amount of shortening. Now, shortening, although will cause limbal discrepancy and bear some abnormal loads, but overall it might not be necessarily be bad from malunion or non-union point of view. Okay, so if we need to correct something, that is to be malangulation. So the first surgery that we do, it has to be the best that we can do to be able to absolutely get our reductions well. Okay. And subtrochanteric fracture is one area where our threshold to open should be very, very low. In the sense, we can try one or two methods, maneuvers to get it closed. We can try with percutaneous maneuvers, but for whatever reasons, if you are unhappy with reduction parameters, then there is no problem whatsoever in doing an open formal reduction. Now, why is that? That is because if you do it close and end up with a mal reduction, then definitely these are going in for non-union or malunion. It's going to be a very risky affair. Rather than that, it's much wiser to open it and reduce it. I'm not telling that we need an anatomical reduction for a subtrochanteric fracture, because principle wise, we all know subtrochanteric fracture is a part of a diaphyseal fracture. In a diaphyseal fracture, a functional reduction is going to be good enough. That is getting the length axis rotation good. But having said that, subtrochanteric is one area where you want it to be as anatomical as possible. Okay. Now, anatomical does not mean that there has to be no gap, absolutely one quart is matching onto the other. But overall, from alignment perspective, if you want to mark it out, then there should not be any angulation, both in varus valgus plane or as well as in the flexion extension plane. There should not be rotations, and even the length should be as anatomic as possible. Okay, so that's what the that's how subtrochanteric goal post is slightly different as compared to any other diaphyseal fracture. In any other diaphyseal fractures, you are only concerned regarding getting the length axis rotation back, not necessarily anatomical. Okay, so look into this. This is a very, very commonest scenario post fixation of a subtrochanteric fracture, that the immediate post-op X-ray will look this, that if you look into this carefully, although we may feel that the reduction is all right, but if you look into this carefully, there is still varus. That means the lateral cortex of the proximal femur is not matching with the lateral cortex. In fact, the medial cortex of the proximal femur is in continuity with the lateral cortex of the distal femur, distal shaft of the femur. Sorry, that clearly means there is the proximal fragment is in significant abduction, which is varus. Okay, AP view. Rotations, we are not really able to comment on this particular X-ray because we do not also have the knee X-ray in the same film. So let us keep that apart. But what is obvious also in the lateral view is that it is significantly flexed. So if you see this, the anterior cortex of the proximal femur is somewhere there, and the anterior cortex of the distal shaft of the femur is somewhere here. So it is significantly malaligned. Although there are cerclage wires or cables in place, but it is not doing much from achieving reduction. Mind you, cerclage will only be able to maintain the reduction that the surgeon has got back. Okay, it will the cerclage don't help to achieve reduction. So this and if you are seeing cerclage, that means this surgeon has attempted open reduction. So this technically is not an open reduction internal fixation. It can only be considered an open internal decoration, because so in subtrochanteric region, if you are going to end up with this sort of a fixation, that fixation is not going to provide any adequate stability to the fracture. And for all we know, I mean, this could be something called a day one failure, where you know that this is going to end up bad for the patient, right? So this requires an immediate revision without any doubt whatsoever. So mind you, always reduction before fixation. So reduce the fractures well and then fix them well. Avoid varus at all costs. Okay. So if you look into this, each of these fractures is slightly fixed in valgus. It may look very slight, very subtle on table. I know subtrochanteric fractures are little difficult fractures to treat, and after a lot of struggle, we may end up in slight amount of varus. For example, this last example over here, we may think that this amount of gap will fill up, but any amount of varus is bad. It's going to end up in a non-union mostly, sometimes a malunion, okay, but not definitely not what the patient deserves or the surgeon desired, right? So avoid varus.